So we are preparing to go live on Facebook, and this will be Facebook Live also on Indians in Paris, which has a huge following of 25,000 people.
Fantastic.
Okay, so I start my presentation. I am Professor Dr. Vivek Gupta. This is also for the purpose of recording, so I have to introduce again and again. I'm Senior Consultant Cardiologist in Apollo Hospital, New Delhi. And this is one of the most important private hospitals with 68 hospitals in India and abroad. And this is the chain of hospitals starting with Professor Dr. P.C. Reddy, a cardiologist who was working in USA. In 1986, he developed one first hospital in Chennai, and then followed by Hyderabad and Delhi, and then they have hospitals all over the world. So I'm proud to be working in this hospital with our director, with Dr. Subramaniam, who's working with us. And so good morning to USA, good afternoon to Nigeria, and good afternoon and evening to India. And so I have to share my slide. This is webinar series number 8. And this is 28th of May, 7 p.m. in India, 9:30 a.m. in New York, 2:30 p.m. in Nigeria, and 4:30 p.m. in Kenya. We wanted few Europeans to join in, but I think numbers were increasing, so we will have it next time. Dr. Jack Lewin wanted to join from USA. I think he will be one of the people who will be watching this, and he's a great admirer of Dr. Stone and also a friend. And so let me show share my this slide so that I can introduce the speakers. This is. I think people can see my slide.
Yeah.
So I have shared my slide. So this is Dr. Gregg Stone on the lower left. He's an apprentice, and he is the Professor Director of Medicine, Director of Academic Affairs for Mount Sinai Healthcare System, Director of TCT, one of the very important interventional cardiologists who started working for angioplasty ever since angioplasty was born with Gandrius Dulcig in 1977, and Dr. Sigwart did the first stenting in 1987. So he has been doing the work with Dr. Martin Leon, and TCT is one of the most important interventional cardiology conferences, more than following of more than 10,000 participants. Unfortunately, because of lockdown and COVID-19, this year it will not happen. I think this must be 28th year, I don't remember exactly, of TCT. So then I have the privilege of introducing our friend from Kenya, Dr. Robert Methenge, who is an interventional cardiologist from Nairobi, good friend of ours, sending patients to us also, and also doing a lot of interventional cardiology. Then Dr. Hakim, he's a senior cardiologist in Katsina city in Nigeria. He is a physician and cardiologist, clinical, not an interventional cardiologist, but doing some cases there. Then Dr. P.P. Mohanan, who is the President-elect of Cardiological Society of India, will join, and he will share some slides later on, especially about the COVID-19 and how to do primary angioplasty. Then we have Dr. V.K. Shah from Bombay. He's actually one of the important cardiologists now, because Bombay is one of the cities worst affected in India. First affected is Bombay, and the number are increasing. Then we have our dear friend, Dr. P.K. Ashokan, who will be, he's from Kerala, Calicut, and friend of ICR. Dr. Yashpal Sharma will give only these people will be giving only 4 or 5 minutes of their thought process. Yashpal Sharma is a PGI Chandigarh, Postgrad Institute Chandigarh is a very important, prestigious institute. He has a department of cardiology and very important interventional cardiologist. When my son, Dr. Chinmay Gupta, Pankaj Jeswani, who's an international singer. My son is a physician and cardiologist doing MRCP. And then Honorable Minister, Mr. Chaube, might join in after some time because he's busy in meeting, tackling the corona. He's a Minister of State for Health and Family Welfare in the Government of India with Modi government. So let me start after this brief introduction. I will start my presentation. I will stop sharing this slide, and then I will show the slide of my presentation. Today I'll be a little brief because I want Dr. Gregg Stone to speak a little more. And my slides are a little complicated, but I'll try to make it simple. So I think everybody's hearing me well?
Yes.
Okay. So COVID-19 SARS-CoV-2 is a real great problem for all of us. It is more than 6 months. Okay, is it? have not, I think I have not slide shared, so sorry. I have to share the new slides now. Okay. So new group of slides have come, and okay. So I think everybody can see the new slides. So this is IECR Indo-European Course on Revascularization. I'm again thankful to Dr. Gregg Stone, who has supported me, although he's much senior to me in age as well as experience. He has supported me all through, especially when he came to our stall in South Korea when we had this meeting. Because of some logistics and financial reasons, we could not do this conference for last 3-4 years, but at least webinar is possible. So SARS-CoV-2, coming on to the topic, is a big challenge for the whole world. Now people are saying that you have to live with it. So I don't completely agree with this notion that you have to live with the virus, which is so contagious. One virus, one person can infect more than 400 people and mortality of 4 to 5%. So we have to really find a solution, and either some repurposed medicine or a vaccine, which is taking time. So global perspective, more than 58 lakhs people affected. I'm talking on lakh. Dr. Stone, you'll mind 5.8 million, and more than 2.5 million death, 25 lakhs death all over the world. India is getting more and more affected these days. I'll show you the data. More 1.59 lakhs death, infected, and for only deaths are little less. But the curve is still not flattening in India. It is going on rising, especially after lockdown 4, which was eased out. The lockdown was eased out a little. So 4,500 deaths. Every day we are getting more than 7,000 patients every day. About 6,000 to 7,000 patients every day, which is not a good sign. America is worst infected. Dr. Gregg Stone will tell again a little more later. 1.7 billion, 17 lakhs people infected, and more than 1 lakh deaths. I would like to show you a few highlights of today's newspaper, because every day the things are changing. Japan is the best to approve funding for $1.1 trillion stimulus. European Union will give about only 824 billion plan. So this is the plan for the stimulus coming from Japan and from the European Union. Deaths have crossed more than 350 as life limbs down in some countries. Deaths have crossed, which is a big number. Dr. Fauci from I think is a part of America, says vaccine is possible this year. So some highlights of today. And then this is an important slide I would like to show you that, this slide, that India is number 10 in country. America is number 1. Brazil has gone up too much. Russia, Spain, Italy has gone down as far as number is concerned. So Italy was the second worst affected, but this is the virus affected tracker today. America is of course number 1 as of now. This is a very important slide I would like to highlight before I start further. In India, rising curve of death and cases. India curve is still going up. And on 17th of May, only 1 week back, there was a lot of ease down. That means they wanted the economy to grow. A lot of migrant workers for America and for Nigeria and for Kenya to know that there are a lot of migrant workers who come from various states to come to different areas of India. You know, India population is 137 crore, 1.37 billion. And a lot of people are working from different states to come. So they were all stranded. And they were stranded and they did not have although the government was supplying a lot of food, but still there were people who were not able to get enough food. So they started going back to their hometown. And when they started going back to their hometown, there were special trains which started with the help of Railway Ministry. And we thought that easing of lockdown was not the right time, but there was so much of pressure on Prime Minister Narendra Modi that he said, okay, the lockdown is there till 31st of May, but he allowed the chief ministers to take their own stand. You know, India is having a country with more than 23 states, and every state, for example, Uttar Pradesh state is a state in itself bigger than America. So we have, as far as population goes. So every chief minister was given some sort of freedom by the Honorable Prime Minister that they can take their own decision whether the lockdown should be eased out or not. And with that, they eased out the lockdown. The curve is not flattening. And earlier it was 3,000 cases per day. Now it is about 7,000 cases per day in India reported. Whether it is because of the easing of lockdown or it is because of more testing, we don't know. But we are really scared. And especially in Apollo Hospital, Delhi, we have more than 4 senior consultants who are infected. I'm also senior consultant, but 4 senior consultants who are not directly seeing COVID. Despite that, they are infected and they are hospitalized. Although we are fortunate that there is no death as such. So COVID count crosses 15K marks. This is the overall international figure today. We take a look of how different countries have enforced and relaxed lockdown norms in different stages of their outbreak and how India is doing. So India has started easing the lockdown despite not having the curve flattened. I repeat this, we take a look at how different countries have enforced and relaxed lockdown norms at different stages of their outbreak and how India is an outlier as it is one of the only nations that has started relaxing its lockdown before the flattening of the curve. This is today's newspaper. For example, Peru, Mexico, Chile, Brazil, United States have started flattening. Dr. Gregg will tell further. UK has started flattening, Spain, but India is still growing up. You can see this slide, and they have started easing the lockdown. So this is a concern to all of us. This is a real concern to all of us. So we have to find an option with the Ministry of Health. That is why I wanted our minister to come and give some highlight. Private hospitals, this is a big news for us. I'm trying to give you the highlights of today and within this week. I have all the chief ministers, especially the chief minister of Delhi, has said that all the private hospitals should have a reserved beds. And now the private hospitals are getting some sort of information or light information that they should allow a free treatment. So the private hospitals, remote control of government leaves many private hospitals sinking feeling. Sinking feeling means they have a feeling that they will not be able to work hard because they don't have any grant. So coming on to our work in Apollo Hospital, as I showed you last time, we are using the face shield to do angioplasty. I have not introduced Anshu Anand, who has just joined. She's actually business and healthcare advisor. And I missed her to introduce her. She will be speaking a little later about healthcare perspective. So this was yesterday, Apollo Hospital. This was a news, and this was actually the people, TV people, one of the important television, Republic Bharat, came to us and they recorded how we are prepared to tackle this as a private hospital. And this was telecast today morning only. So I've taken the picture sent by other friends and shown it to you. So we are doing angioplasty regularly. Economic burden is huge, not my topic. I'm skipping this slide. This was Angela Guria speaks to France 24, the international channel. So economy is worst these days. This is the second most. I'm skipping this slide also. The viral disease, antigen, antibody formation, vaccine is important. Antibodies are important for the plasma treatment and what other people have shown. I think I have to mute everybody because some disturbance is coming from other places. I will request everybody to be, whosoever has not muted, please mute themselves. Okay, so corona S virus protein, not putting details. I'm telling it every day. So virus part, I'm leaving it for the virologist to tell because I have a limited time. So antigen presentation in coronavirus infection, then antibody presentation, which is IgM antibody and IgG antibody. IgM antibody, they disappear at the week 12, while IgG antibody, this is important for testing as well as for plasma treatment. This we all know. I repeat for the people who are on Facebook Live, who are not medical people, to know a little about the virus part. It is. Cytokine storm is the worst thing which happens at the end of this when the patient is dying. And this cytokine storm will trigger a violent attack by the immune system of the body, causing ARDS, acute respiratory distress syndrome, and multi-organ failure. And this is the last point. The diagnosis is basically made by the symptoms, which is cough. And Greg, I would like to tell you, yesterday I had a small running nose. So I was a little worried in the evening yesterday, but I knew that running nose is not a symptom of corona. So I was little, then I took one more extra tablet of hydroxychloroquine. I thought, let me be safe. So the running nose is not a symptom, dry cough, and respiratory symptom is dyspnea and pneumonia. The diagnosis is made by the by the antigen test RT-PCR, which is available. And let me tell you that this is a very important test, but this can also be false negative, especially. So this false negative rate is although slow, but it's still there. If you have a classical symptoms of cough, fever, and dyspnea, and oxygen saturation going down, go for the CT scan, which will make the final diagnosis. So this is auxiliary treatment. The testing is key to success. PCR test is the gold mine, but still is having negative test. Antibody test will tell you the exposure part. Let me tell you that although the National Institute of Virology, let me tell you to the international people who is listening, National Institute of Virology Pune has developed India's first COVID-19 antibody kit test. As I told you earlier also that China had sent a lot of kit and they were found to be fallacious, faulty, and therefore Indian Council of Medical Research had to send it back. Whether it was actually planned or deliberate or it was by chance, that most of this kit were returned back to China, not blaming them, but generally it is there. Testing is being helped. We are planning that 1.25 lakhs RT-PCR tests per done. That means 125,000 tests should be done every day. This is the plan of 9th May. So testing is key. How the medicine works. I have told you that hydroxychloroquine works at the level of membrane fusion endocytosis, while remdesivir works at the level of RNA-dependent polymerase. Hydroxychloroquine, I spoke last time, but the latest guideline today, lot have been said and lot recently Lancet has actually created a lot of flutter all over the world, and WHO has stopped the trial what was being done. But I still believe that this is important, SALT personally, and also Indian Council of Medical Research. Giving you the highlight, the French cardiologist was the first to actually ignore, and during his submission in February, he said it is a useless salt. And later on, in April 9, he said it is very useful, and he published the data with 91% success of hydroxychloroquine, the treatment, and death of only 0.47% death. So this was a turning point. And at the same time, just before that, Donald Trump, the president of USA, he actually was very much after India, and he got imported a lot of hydroxychloroquine. Later on, whether it was Trump versus WHO, whether it is America versus Republican versus Democrats, we don't know. There was huge furor, especially by some study coming from America itself, which showed that this is useless and this is causing more mortality. FDA had guidelines for 28th March and later on 25th April for the emergency use. But I want to give you two highlights. One is Lancet article 5 days back. They have tested about 25,000, not tested, retrospective analysis of about 25,000 patients. They have said, mostly from America, they have said that this is actually increasing the death. But I have not the copy of that, but I have read the limitation of that study, that the study limitation is that they have taken mostly serious patients, mostly patients on ventilator, patients who are obese, having comorbidity. So I would take that study with a pinch of salt, but depending on that study, WHO has stopped the trial which is going on. But Indian Council of Medical Research Director General came in the news because they have recently stated the guideline that this should be still taken for prophylaxis for healthcare workers. So we are not worried. We are not going by the Lancet article. India is going with the article because it has shown antivirus effect. So I give you, through this message, I want to tell all the healthcare workers of India and also the policemen who are working in the field to take prophylaxis of hydroxychloroquine, 400 milligram only one day, and then 400 milligram once a week for 7 weeks. This is the guideline again coming. Despite the Lancet article, ICMR, Indian Council of Medical Research, which is a very important body, has given a guideline that one should always use this, and it is not cardiotoxic as much as it has been told. If you can see the QTC interval, then you can use it. Only thing which I want to tell about this repurposed medicine is, I always give my credit to my father, whose photograph is not there. He has seen that he has given an indication to the Indian Council of Medical Research and the Prime Minister Office. My father has been a very keen researcher. Only 14 days trial, for a drug which is repurposed medicine for use for something else, and it is going to be approved very soon. And if we find this is useful, this will be useful. Ivermectin anti-protozoal, already FDA approved for the protozoa, has been in trial in America. Human trials are on. If this works out positive, we can really save people from the world. Not much to say about that. This is trial will tell. Remdesivir is not available in India as of now. This is a patented drug being used and FDA cleared by the people from USA. Being cleared and USA, I think I have to stop in a video by. Last thing which I always tell to the people who are on Facebook Live, that mask and angocha, gamcha, hanky for everybody who is going out. On 26th March, I spoke on TV. On 29th March, again, I spoke on TV. Although the guideline came on first week of April with the Honorable Prime Minister himself wearing angocha and gamcha at that time. Vaccines a long wait. So I will finish this talk at this point of time because we have a questions with Dr. Gregg Stone to speak, and I'll speak a little later. Once in the end, if I have time, I'll finish my talk. So thank you very much for telling about this. I want to show you this video which I spoke on 26th March, and this video which I spoke on 29th March. So this was actually now in India. I would tell you to the international people who are listening, it is mandatory to wear the mask or hanky or covering the face, either with a face shield or something else. So this is what's going on in India. So let me stop sharing the slide now, and I come back to the picture, and I will request, again, I welcome everybody whom I have missed it out. A lot of people are listening. Facebook Live on my Facebook Live. Facebook Live on Indians in Paris, which has 25,000 people. Not everybody is listening, but we expect about 5, 6, 7,000 people are listening. It will be repeated again and again. So this webinar is very, very important for all of us. Our Cardiac Surgery of India president will speak later on. So I now welcome Dr. Gregg Stone, who is a celebrity today for this webinar. Although I have a lot of respect and I have great friendship with him, and I really welcome him. And I've given him his introduction that he's a PCT course director, but he's also professor of medicine, Mount Sinai Hospital, taking care of a lot of things with the government as well as non-government. And he's the most educated and most learned interventional cardiologist I've ever seen. Thank you very much for Dr. Gregg Stone. Please welcome, please start your talk.
Well, thank you very much, Vivek. It's a great overview, and you've asked me to give you an update as to what's going on in the United States and perhaps talk specifically about management of ST segment elevation myocardial infarction in the COVID era. So first of all, to give you kind of the United States overview, of course, the US has been hit hardest of anywhere in the world with COVID, and it's truly changed our way of life. We've now had over 1.7 million cases of COVID-19, and we had the inglorious announcement yesterday of having over 100,000 deaths. So this has truly affected a huge segment of the population. Now, if you look at the United States, though, it's 50 different states. And within those states, there's a variety of different regions. And it's actually remarkable how regional the variation is in COVID-19 penetration. So there are about a third of the states in which COVID is markedly decreasing. And I'll talk about why in a minute. A third of the states where I would say the number of new cases per day is relatively flat, and about a third of the cases where the incidence of COVID is still increasing. And even within those states, there's regions where there's almost no COVID-19 and then almost a true epidemic of COVID-19 cases. So it really depends on social distancing, wearing masks, and the kind of crowding, other socioeconomic conditions, et cetera, that have taken place. In New York, we've had about 30% of all the COVID cases in the country. So by far the greatest penetration has been in New York, and about half of that's been in New York City, which is where I work. We've actually decreased COVID by about 85 to 90% compared to its peak in New York City. So it's been a remarkable reduction. We were getting, in New York, we were getting up to 10,000 new cases a day, and now it's down to about 800, and that's all of New York. And New York City is now down to just several hundred. We used to be getting 200 admissions a day in the Mount Sinai hospital systems of COVID-19. Now it's down to 10. So it's been a remarkable reduction, but the city is totally shut down. I mean, for those of you who have been to New York City, you've never seen anything like it. I mean, it used to be you couldn't, walk 2 feet without, bump. It says I'm muted by host, unmuted. Okay. And now, of course, there's very few people on the street. The only people that are out are to go to basically pharmacies or to pick up food. Restaurants are still closed in New York City, although they do allow takeout. So for the most part, people are sheltering in place. And you mentioned hydroxychloroquine. Most people in the United States do not take hydroxychloroquine. There's still not firm evidence. We don't have any randomized trials that hydroxychloroquine makes a difference. It does have antiviral effect, in vitro, but we don't know if it makes a difference in humans yet to either prevent or treat the mild manifestations of COVID-19. From observational data, it doesn't seem like it treats severe COVID-19 very effectively. So most people are primarily preventing COVID-19 from social distancing. And it's basically staying at least 6 feet away from people, 12 feet away if there's any physical activity, wearing masks, and then mostly staying indoors and not going outside unless it's absolutely necessary. Anybody who's exposed to somebody with known COVID-19 needs to spend 14 days in quarantine. And these are very drastic measures, but I think there's a lot of relevance to what's going on in India because it has markedly reduced the number of COVID-19 new cases. We're not out of the woods yet. And right now, what's going on in the US is that the government is talking about reopening. Of course, the economy has been devastated. We had an extremely strong economy before COVID-19, and now the economy is much, much lower. We've got over 30 million people who we had unemployment of about 3%, the lowest unemployment rate we had seen in 50 plus years. And now more than 30 million people have become unemployed, and the unemployment rate is above 10%. But of course, the economic principles are still there, and we believe the strength is still there, but it's a matter of how fast the economy can reopen. So on a city by city and state by state basis, we're starting to reopen some states and some regions. And it's being done very thoughtfully and very carefully. For example, some states will allow now meetings of up to 3 people or up to 10 people, but not large crowds, nothing more than that. Large celebrations, parades, sporting events still are not going on anywhere in the United States. In terms of restaurants, some restaurants in some regions have been allowed to reopen, but they can only sit at every other table or have occupancy limited to 25% of their maximum capacity to try to keep the 6-foot rule, to keep distance between people. Servers have to wear masks, et cetera. So we're nowhere close to where the country wants to be. And there's obviously a lot of great concern since that we're reopening now before COVID is not at 0, that there's going to be a surge of new cases. And we're looking at that carefully. We haven't seen it yet, but we'll have to see if as we relax the social distancing rules, there are going to be many people that don't follow those rules, and we'll have to see if that leads to an uptick in cases, because we don't have any effective prophylaxis that we know right now. This obviously has had a major effect on medical education, how we take care of our patients. Just in terms of medical education, we announced yesterday that our TCT meeting, which is actually over 30 years, about 34 years now, for the first time is going to be canceled and held virtually. We're exploring, we usually have 12,000 people or so that come to TCT. It was supposed to be in Miami this year in September. We're going to have some very novel, new digital electronic ways of interacting and having virtual training. We're still going to have a lot of live cases, late-breaking trials, abstracts, invited lectures and sessions, et cetera. All this will be archived on tctmd.com. So we are going to try to make the best of the situation. We talked about having a small parallel. We thought about having a small parallel meeting, perhaps several thousand people in Miami, but ultimately just didn't think it was responsible yet to be able to enable a large group of people to meet, even if it's feasible. We don't know if it's going to be feasible in September or not. Of course, right now, travel to the United States has been restricted from most Western European countries and most recently Brazil, which of course is the most rapidly increasing number of new cases in the world right now. So there's no doubt that our lives have been changed. COVID-19, I don't think is going to be eliminated this year, but hopefully by the end of the year, it's going to be markedly tamped down. I think in the end of the year in the United States, I'm hopeful that the whole United States will be about 90% reduced in terms of new COVID cases. Right now, we are slowly reducing. I would say it's about a 10% reduction month over month. So we still have a long way to go, but we're making progress. In terms of the hospitals, again, it's very regional as to what the hospitals are doing and how much they're opening up again. The Mount Sinai, healthcare system, was running 12 to 1,500 inpatients per day with COVID-19. The hospitals were 90% COVID patients. All the ICUs, the cath lab holding areas were turned into COVID ICUs. So it was really quite disastrous. But we never ran out of personal protective equipment. We never ran out of respirators. We were able to manage and get through it. And as I mentioned right now, we have where we had more than 1,200, we have now about 200 COVID patients as inpatients, and about half of those are in ICUs. So we've made marked reductions. We've now been able to open up some of the ICUs to be general ICUs. So we have separate COVID ICUs from the regular intensive care units, and same for the CCUs. We've been able to open up the cath labs, not for elective cases yet, but for what I would say would be more urgent cases or high-risk cases. So patients now with triple vessel disease, or patients with increasing angina, or patients with severe aortic stenosis with symptoms. Now we're doing those patients, where for about 6 weeks or 8 weeks, we hadn't even been doing those patients. We'd only been doing true emergencies, such as ST segment elevation MIs. So we're now starting to open up to those semi-elective cases. And I suspect over the next month, at least in New York, we'll be back to being able to do a full complement of elective cases. The real question is, though, will patients want to come back to the hospital? And right now, patients are very nervous about leaving their homes, let alone coming to the hospitals, which of course they think are the hotbed of COVID-19. And to some extent, they're right. We've been using, the Abbott rapid COVID-19 test, PCR test, but, it's been associated, as you said before, with false negatives. So while it's very fast, we don't know if those false negative rates are a problem with the assay or the way people are using it, but it's led to a lot of uncertainty. So when we have ST segment elevation MIs right now, and you're not confident on the COVID status from a true lab serologic test of PCR, then we take the patient to the cath lab for primary PCI, but we're using full PPE. And of course, that's not so difficult because, of course, we were always gloved and gowned and we were always wearing masks. The biggest concern is if the patient needs to be intubated. And of course, some patients in the cath lab deteriorate and need intubation. And that's really when the risk period is for spreading respiratory droplets. And that's the biggest risk to the staff. So we try to stabilize patients as much as possible hemodynamically before taking them to the cath lab. But that being said, we haven't changed our treatment of STEMIs. It's still primary PCI. We really have not used lytic therapy. Again, we've always, for patients transferred to us, if we thought the door to balloon time was going to be greater than 120 minutes, then we would use lytics. But for the most part, that's very rare, and we just don't use thrombolytic therapy, even in the COVID-19 era. The last thing I'll say is, of course, everyone is aware that the number of STEMI cases has gone down markedly in the COVID era. That's internationally. We don't know exactly why that is, but we think most likely it's because people with mild symptoms or atypical symptoms that usually would be worried and would come to the emergency room are now staying at home. And the one thing we have noticed is that we are getting a higher incidence of patients that are presenting late. And the patients are presenting late with mechanical complications of myocardial infarction, such as VSDs and papillary muscle rupture with mitral regurgitation, complications that we haven't seen in a long time. for the most part, because we get and treat patients early and we can prevent transmural infarction with those complications. So that, of course, is leading to increased use of mechanical circulatory support in STEMI patients, including Impella and ECMO, et cetera. Last thing I'll say is about treatments. Again, very early on, there was the empiric use of hydroxychloroquine. I think most people do not feel that hydroxychloroquine and azithromycin works in severe COVID-19. We're waiting for randomized trials in less severe cases or as prophylactic use. I think it's a relatively safe drug in patients who are healthy, especially if you take a low dose of it. But we've definitely seen QT prolongation in hospitalized patients with electrolyte disorders, et cetera. And it has been associated with increased cardiac death rates. So we really need to see the randomized trials. Of course, the one positive randomized trial we have that we're excited about is with remdesivir, the antiviral agent from Gilead. And that was shown in the ACTT1 trial to reduce fairly substantially the time to recovery from 15 days on average to 11 days. There was a borderline reduction in mortality in that study. These are all still preliminary results, but it was just published a few days ago in the New England Journal. But a borderline reduction of mortality with a hazard ratio of 0.7 and a p-value of 0.06. So favorable results. It seemed like it might work better, though, in the mild to moderate cases than the severe cases. While there wasn't a significant interaction, there really was no signal of benefit in patients who were intubated or on high-flow oxygen or non-invasive mechanical ventilation. So we've really got to get more data with that. And there's at least 2 more randomized trials of remdesivir, large trials, that are highly enrolled or completed enrollment and will report out soon. So I think we will get that answer. The last treatment that we are interested in, highly interested in, is antithrombotic therapy. Patients with COVID-19, when you look at the patients who have died, they have many of them have a picture of disseminated intravascular coagulation. And a lot of these patients come in with high fibrinogen levels, high D-dimers, et cetera, abnormal protimes, and they're clotting. And you see particularly small vessel clotting and venous clotting. This can contribute to the pulmonary manifestations and the difficulty in oxygenating patients with COVID-19. So there's been a lot of excitement. Almost all the patients are on prophylactic heparin, low dose of subcutaneous heparin or low molecular weight heparin in the hospital. But the real question is, should they be on systemic doses or should they be on apixaban? And there are randomized trials of this going on as well. So right now we're tending to treat the sicker patients with higher doses of heparin or low molecular weight heparin, or even standard dose of apixaban. But again, that's very empiric, and these patients also have an increased bleeding risk. So we really don't know that that is going to be a safe and effective therapy. So we urgently need more of this randomized trial data. The good news is I think within the next couple of months, we're going to see a lot of randomized trials, and I've got no doubt that our standard therapeutic regimens for COVID-19 are going to change. So I'm going to stop there and be happy to take some questions. Can't hear you, Vivek.
So thank you, Gregg, for giving a very nice overview of what America is doing. I have 1 or 2 questions myself. But before that, I think I will invite our international speakers to speak for 2-3 minutes. And they will be introduced, especially from Dr. Nigeria and Dr. Robert Mathenge from Kenya. So I request Dr. Mathenge to speak a little, and then I'll take a consolidated question. I have still 20 minutes with you. So Dr. Mathenge, are you ready to speak? Dr. Mathenge? I think he's just left. So I think he's getting ready. Dr. Mathenge, good morning.
Hello.
Yes,
hello. Can you hear me?
I hear you, but I can't see you. You have to, yeah. Okay, fine. Perfect.
Yes. You would like me to speak now?
We'll just speak for 3-4 minutes, and then we'll take questions. Dr. Hakim will speak from Nigeria, and then we'll have questions to Dr. Gregg.
Okay, very well. Okay, Vivek, it's a great pleasure to see and hear you. We have met physically for some time now, but it's a pleasure to see you looking great and see everybody else looking great. Here in Nairobi, I'm in Nairobi, Kenya, in East Africa. Sub-Saharan Africa. Kenya is a country that has a population of about 50 million. Remember that Africa has about 1.1 to 1.2 billion people. And of course, I see my colleague from Nigeria is there. His country is the most populous country, 200 million people. Also, he'll probably tell us that. Now, our, what, have you, sorry, Vivek, have you, I wanted to show one or two, just two slides.
Okay, go ahead.
Can yes, you seem to have disabled my screen or something like that.
No. You can show your slide. You can share a screen.
Host disabled participant screen sharing. That's what mine says.
I'll make you co-host. Now you can do it. You can do it.
Okay. Right. Okay. Yes, this one.
Can you share the slide now?
Yes, just about to. Just about to. And then
okay, I can see your slides.
Yes, you can see my slides. So now I wanted to say that I think from what we are seeing here, we are seeing a slightly different picture from what the rest of the world has been seeing, right from Wuhan going to Italy, going to America. And we've been wondering, is the impact of COVID on various societies, does it have something to do with the stage of epidemiologic transition that we are in? In that regard, you can put a slide there of this epidemiological transition stage, and I wanted to say where we might be at this particular time. Everybody started at the pestilence and famine level, where the life expectancy was very short. Then we went into methods, antibiotics came up, receding pandemics, smallpox, TB, all those diseases, and the life expectancy went up at that particular time. And most of sub-Saharan Africa, maybe my colleague will confirm that, maybe is at that stage, moving to the third stage there of pandemics. The second stage where actually we are going from this country in sub-Saharan Africa is the degenerative and man-made diseases. This one now there's going to be a transition between from communicable diseases to non-communicable diseases driven by diabetes, hypertension, etc., obesity, and that can estimations of about 2025 we'll hit that transition. That transition obviously has come. The is probably the next stage where now you have the degenerative disease, which have come in life. In that respect, you can see the you can see the populations. Okay, can you get this out? Okay, sorry about that. And now you can see those stages as they are. The first stage there you see that stage in the famine and pestilence stage where you have very high mortality, very high birth rates to try and compensate for the dying children, but the population is very low. Most of sub-Saharan Africa has moved out of there, but there are segments that Africa is very varied. There are some segments that might still be there. Then as now you come to the receding pandemics, you have your death rates coming down because you are controlling all these infectious diseases. And in the developed countries, the pandemic of coronary artery disease also started coming here. And that's why now also they managed to come down here. So in other words, at that particular time, the populations are going up. We find ourselves now around here in sub-Saharan Africa, particularly in Kenya, where we have markedly reduced the death rates, the death rates to a certain extent, but we have not completely overcome that because the first heart attacks in our population is still below 60. In the West, I believe that can be confirmed. The first heart attacks in men is about 65, and in women about 72, shifted in the last 50, 60, 70 years. We are still there, and what we are seeing now as an impact, you can see, you can see finally the impact here in the developed world, in the high-income countries, where now the death rate is very low. The birth rate is very low and actually goes below the death rate, and the population starts coming down. So in other words, where we find ourselves now as a country, and we think that has an impact on how COVID-19 is affecting us, is that our population under 30 years is 75%. Our median age is about 19%. Under 65, over 65, we only have 3.4% of the population compared to over 15% in the USA. Now, if you look at that we have a slightly younger population, but remember the global burden of cardiovascular disease is in the low and middle income countries, 80 to 85%. So although our people, our cases are younger, our people are younger, they are likely to succumb more from the higher prevalence of cardiovascular disease. In fact, looking at a little data that I saw here in a small group of patients from Nairobi, about 200 or so, about 36% had pre-existing heart conditions, and those are people who are between 20 and 60 years. So our first case was in March of this year. We now have 1,500 cases. 50. We are very nice. We are not overwhelmed. For some reason, we have managed to, we have escaped so far. But I'm not sure that we are not sure that we have fully escaped this. But our concern is that although our suspects are the young people I talked about, 39, and these are, of course, infected now 50 to 60, who are the ones who are dying at the prime of life. We don't have people dying in retirement who are retired or in retirement homes. Now, the final word I wanted to talk about is STEMI. We have adopted here because there are challenges. Patients are coming late. I just had 3 days ago, somebody come in cardiogenic shock after 3 days of pains in the chest. So what we are doing here is we are adopting the pharmaco-invasive strategy, which Dr. Gregg Stone alluded to. That allows us, number one, to understand the patients better. Whenever we have about 6 labs in Nairobi that can do that, but they are scattered. They're only in Nairobi and one other city. We do not have out in the country. We have no capability for primary PCI. So in other words, what we are doing in the city, those who are able to come, if the circumstances are very correct, we go in for primary PCI with the full PPE. But we know that the safety, if you give, you do it the pharmacologic, thrombolyze, and then within 24 hours, take to the cath lab, that patient is safer. That patient is safer to the healthcare worker. And that's what we are trying to encourage, because we're not too sure that we'll be ready to treat these patients safely. So now we know we have a challenge. Even before COVID, only a few people around Nairobi could attain primary PCI. So what we are rolling out is out in the country is latex centers from which now patients through a referral network can be brought to the hubs. So we are actually adopting the hub and spoke model, which is very well established in parts of India. And that seems to be the only model for us, because we only have cath labs in Nairobi and the skills in Nairobi, and probably in Mombasa, very limited skills, which is about 300 miles away from where I sit. So in other words, in conclusion, so far, for some reason, we have not been overwhelmed. We have very few ventilators, they are not overwhelmed. We have very few ICU beds, they are not overwhelmed. We thank the creator for that, but we are seeing a little bit of increase in the low socioeconomic state where preventive measures for COVID are not easy to sustain. That's where we are worried, but so far, so good. Thank you, Vivek. I think I'll stop there because I know you only gave me 3-4 minutes, but I exceeded that.
You see, actually, let me unmute. So actually, the problem is that Dr. Stone has to leave, and we have a lot of questions for him. So I would not be able to request anybody else to speak, although I can introduce Dr. Hakim from Nigeria is waiting. I can show his face if he's there, but I think his video is still not on. So let me have some questions coming up for Dr. Gregg Stone from Dr. Yashpal Sharma, Jatinder Singh, Dr. P.K. Ashokan, and yourself. So let me start the questions from my side. Dr. Stone, let me start a few questions from my side. You said that New York is closed and you are not using hydroxychloroquine. And so there is no preventive medicine you're using. You are just dependent upon social distancing and sanitization and all. Is that enough? I mean, this is something in my mind, because when my policemen, I'm talking to you, a lot of policemen who are getting infected in India. So I always tell them, if your QTC is okay, go for hydroxychloroquine. Nothing else which is being touted as a preventive agent. What is your thought process? Social distancing is not enough, I think. What do you think?
Well, again, we all wish that there was a proven prophylactic pill that people could take and that we know it would work. I'm a big believer in evidence-based medicine, though, and every drug can have side effects. Another concern about taking a medication is that it may give you a false security that you think you're protected from getting COVID-19, and then you don't practice effective social distancing and wearing masks and washing your hands and not touching your face and all those other common sense items. So for the most part, we don't recommend therapies until they're proven. I understand the desire, and I understand that people feel that there may be a low risk, but until we really have large-scale randomized trials, we just don't know that for sure. Most people who take hydroxychloroquine are not going to get an EKG, are not going to have a 12-lead EKG, and they're not going to have a serial 12-lead EKG to see if their QT interval does prolong. And then what happens if they do get dehydrated and they get hypokalemic? And, we just don't know yet. And that's why we believe in doing the trials before recommending treatment. There's a lot of agents that in vitro, in a test tube, have activity against viral drugs and against viral particles. And many of them have never been shown to be effective when taken in patients. So we just need to see the clinical trials. That's our.
I want to share one doctor who was in Apollo Hospital, who is still working. He took hydroxychloroquine prophylaxis. He got infected. Hydroxychloroquine does not prevent infection. It may reduce the virus load. So he's doing well. Doesn't matter, but we have to take the guidelines from your country. Anybody else? Some other question from Dr. Yashpal? Let me show the face of Dr. Hakim. He's from Nigeria, but I will not request him to speak now. So I think Dr. Yashpal Sharma want to come in and join and speak something, some only questions rather than this. Dr. Gregg Stone has to leave in 10 minutes.
And just one question to Professor Stone. You said about the default strategy in STEMI's primary PCI. So I'm Mohanan is speaking.
Oh, no, okay, I'm not able to see you. Okay, yes.
Okay. And then you said the default strategy is primary PCI, and as with the community spread coming up and asymptomatic COVIDs all around, do you use PPI in every case of primary PCI?
Yeah, right now we still are. We're still using PPA in every single case. And I still think that's prudent. We obviously want to be protective of the healthcare staff. And again, you may only have to intubate 1 in 200 or 300 people in the cath lab, but that's where the real risk is. We're also concerned about, even if we were to delay, the Abbott rapid PCR test takes 13 minutes to give you a negative result. But even if you do accept that 13-minute delay, there could be as high as a 1 in 4 false negative rate. So right now we're still using PPE for all of the STEMIs.
Every team member uses it?
Every team member.
Dr. Gupta.
Yes, let me introduce Dr. Yes, this is Dr. P.P. Mohanan. He's the President-elect of Cardiological Society of India. He will be speaking about STEMI, as of now in COVID-19, but little later. So Dr. Yashpal Sharma wants to have some question. Let me see his face. Dr. Yashpal Sharma is a professor and head cardiology in PGI. So please go ahead with your question to Dr. Gregg Stone.
Dr. Gupta, my just comments are there. As I earlier told in different webinars, that in PGI, our approach has been slightly different. Just like comorbidities, ACS with comorbidities, cardiogenic shock. Basically, we have experience of COVID-1, H1N1, MERS, and all cardiogenic shock. We never took the patient with sepsis immediately to cath lab because PAMI and all cardiogenic shock, they excluded those patients. So our approach was to stabilize with pharmacoinvasive the lies, and after 4-5 hours, 2B3A inhibitors. 99% of the patients, they never used to have any pain post-infarct angina, even ST segment elevation, or even late presenter of cardiogenic shock. They also became normalized, and we published in Indian Heart Journal last late presenter of cardiogenic shock also. Our ACS real world registry is under publication. That will also be there. But with that approach, we had some few patients of COVID, and they became negative within 6-7 days with treatment. And after that, they were on medical treatment and they were planned very nicely. Basically, earlier we were not doing any viral test. As you know, COVID-1 was also there, MERS was also there, H1N1. So during that December to March, there used to be very high mortality. In 2005, we used to do angioplasty, but when we picked it up that in infected patients, the mortality is more, we immediately moved to stabilize the patient, sepsis treatment, and very integrated protocol. With that, we this one in the TCT last San Francisco, we this read a paper also that we had the least mortality of cardiogenic shock. Basically, it varies from 20 to 40%. And with this approach, by decreasing the mortality of cardiogenic shock, we could take a lead to decrease the ACS mortality to lesser between 7% only. So that is our achievement from PGI, and we are advocating to whole of the world that with sepsis, one should go for this approach. Because if you mix because at this time in our India, there is not a community spread. We are able to separate COVID positive and COVID negative. But as you say, in United States and other countries where this one was not possible, so mixing also led on to the spread, contagious spread to the other patient also. So that was unfortunate because so many patients came to the hospital with community spread. So if we are able to have prevent the community spread, and that may be the better. So this is basically for India also, that we should not enter in a stage where too much community spread is there, just like Bombay. But I think your lecture was excellent. I met you earlier. Thank you.
Yeah, I have to, let me respond quickly because I have to unfortunately get on an FDA call. But, you know, it's a very interesting approach. All I can tell you is we have very strong beliefs about cardiogenic shock, about taking people to the lab as soon as possible. Those patients treated, you know, conservatively or with thrombolytic therapy in general had 85 or 90% mortality rates without COVID-19. And the only thing that's been shown to be effective has been early reperfusion. Now, if you wait and try to stabilize the patients, if they have true shock, if they've got a blood pressure of 60 and you try to use high dose norepinephrine and epinephrine and other pressors, et cetera, maybe a balloon pump, which isn't very effective in true cardiogenic shock, then you're going to have a lot of early mortality. So the survivors who get through 5 or 7 days, then they'll probably do okay. But I think in general, we still recommend that patients come to the lab early for shock, that they have effective mechanical circulatory support to rest the ventricle. In most of those cases, we would use Impella, forward transaxial flow pump, but in some patients, ECMO, but Impella works for most. Try to minimize pressors, get the artery open, and we still think they have the best survival with that approach. But if you feel strongly about your approach, I'd really recommend doing randomized trials. And of course, there are so many patients with STEMI in India. You could complete that with the right kind of coordination.
Basically, we had double-blind crossover study with observation study also. When we used to treat, because there is so many patients in our CCU that even observation, if some patients are treated like that, some patients are treated like that. We used to
it's not the same as a randomized trial.
Professor,
so you're never going to convince me that you can't, you don't
Professor Peter,
I have to go, Dr. Gupta, so thank you very much for this invitation. Obviously, we're all learning together, and we can just share our experiences. obviously we were not proud of having 1.7 million cases and 100,000 deaths. So I'm not saying that we know everything about COVID-19. Nobody does. We're all learning together. And I really do believe we need really good science, randomized clinical trials more than ever to teach us how to effectively reduce the morbidity and mortality of this disease. So thank you very much. I appreciate the opportunity to speak.
Thank you very much, Greg. We'll have you again after a few weeks' time when we'll have more time, and we'll have more speakers now, and I'll send you the recording later on. Thank you. You go ahead with your meeting with the FDA, is it, or WHO? Okay. So I come back to the presentation and part. I think I will take Dr. Mohanan to present the slides related to COVID-19. Is he available now?
Oh, I'm here. I have only few slides. Don't worry, Vivek. Can you just, it is disabled, the screen sharing. Can you do answer it?
No, just hold on. Hold on. So I made you co-host. Now you can do it. Can you share the slide now?
Sure. I will do it in a minute. Hopefully you can see it.
Yeah, we can see that something is coming up, not yet the slides. You have started sharing the screen, but it is, yes, now we can see. Okay. We can see mountain hills.
Right. Basically, you have already discussed about this particular slide. Just wanted to tell you the India is there on 10th position. The only possible thing when you compare with the other countries, fortunately, we are having a lesser number. Okay.
We can't hear.
Your sound is not very clear. Can you speak a little more into the microphone?
Maybe I will stop my video. The only good thing, solace, if you look at this particular slide, is that our death rate when we compare ourselves to the other countries are lesser, but the numbers definitely are increasing, and that is a real cause for worry. Basically, Vivek wanted me to just focus on the primary PCI in STEMI, even though you would have seen, at least some of you have seen some of you have seen the position statement of Radiological Society of India. The default strategy in a COVID situation of a patient is lysis. As our Espal has said. So, but then there are instances where you have to consider primary PCI. But then before you consider a primary PCI, please pause and think about this. What about the prevalence? We don't have, we always proclaim that we don't have a community spread. But that is very unlikely. We definitely have a community spread. And it is not possible to do a RT-PCR prior to a primary PCI. We have to also see that there are so many ST elevation mimickers, STEMI mimickers during COVID. So one has to be also careful about that. Maybe a bedside echo, or a cautious echo, and if it's showing a regional wall motion abnormality, will suggest that possibly this is not a mimicker. Another important thing you have to see is your door to balloon going to be running properly? And more importantly, what is the routine, the personal protection equipment of this patient? We just listened to Professor Stone, who said that they use a PPE in every primary PCI. Mind you, we have about 1,200 cath labs in India, approximately. It may be more. This was last year's statistics, mostly in Tier 1 and Tier 2 cities. But how many of them have a twin cath labs? And how many of them possibly can afford a PPE for every member? So these are the things that one has to keep in your mind when you attempt. This was a slide from Lombardy area, which just tells you that there are very many STEMI mimickers during this COVID situation. As you could see here, at least nearly 50% of them with the STEMI had no significant culprit lesions. So that is something which you have to keep in your mind. I was talking about the CSI position statement. Essentially, we have divided into the any patient with STEMI, a confirmed COVID or a suspected COVID or low probability of COVID. You have a low probability of a COVID, then definitely the easiest thing for us to do will be straight away take him to the cath lab and go ahead with primary PCI. Otherwise, unless, fortunately, in some of the state there are dedicated COVID hospital and the COVID hospital with a COVID team. Not the entire cardiology team is there. They can restructure the team and specifically utilize some of the cardiologists and the residents for cath lab purpose. So in those situations only you will be doing a prime, or otherwise a patient is hemodynamically unstable. So these are the only situation where you attempt primary PCI in at least in our country. As I said earlier, the default strategy is generally blast. Something to be just that.
We can't hear. The voice is not clear.
Confirmed and suspected COVID patients cases, it is better that you with so even though we are aware that the primary PCI results are definitely better. You have a 6% difference between the lytic group and the primary PCI group in the 30-day mortality. So when you are attempting a primary PCI, caution has to be there before the intervention, during the intervention, and post-intervention. I will not be possibly reading the entire thing, but then generally the major things that you have to keep out, you have to have a dedicated cath lab room, a cath room with a level 3 personal protection. And at least what is possible is at least the 3 of the members can be using the full range of PPE. The others can use a N95 respirator. Only use the essential equipment, prevent patient from entering the waiting area after the patient enters the cath lab. Minimal and use oxygen only if it is absolutely necessary. And somebody has muted me, please unmute me. Okay, and during the intervention, basically maintain negative pressure. Try to, any aerosols are dangerous. Do not go outside the room, minimize the contamination. Every medical waste discarded in a double-layered medical waste. And after the intervention, again, this is, all of you are familiar with donning and doffing of your PPE. So cleaning part, doffing part, these are the things that one has to be very, very careful. I don't need to tell about the PPE. Every one of you are aware of the level of personal protection equipment that you should be wearing if you are attempting a primary PCI actually in a suspect patient. Professor Stone mentioned about the disappearing STEMIs. What we are seeing is a substantial decrease in the incidence of STEMI, and that applies to India. Unfortunately, we have data from USA. We have you would have seen the data from New York, 9 hospital data, which has shown a 38% decrease in the STEMI. Also, a Spanish data, which almost about 40% decrease in STEMI. We don't have our own data. The CSI is definitely trying to get some data. This is the NH, the National Health Mission data, which has shown a 30% decrease in acute admissions to the institution of acute cardiac emergencies. It's the only data from India that we have, but I can promise you that possibly we will be able to get some data. And thank you, Vivek, for your the opportunity. And definitely let us have some discussion after this.
Thank you. Can you stop sharing the slides and I can see you? Dr. Mohan, can you stop sharing the slides yourself or I'll do it? Dr. Mohan? Stop particle sharing. Okay, so it's better now because he could not stop, so I have to stop it. So, okay, so it was nice, Dr. Mohan, who's the President-elect of Cardiological Society of India. He spoke about something. Actually, Hakim from Nigeria was supposed to speak, but unfortunately, he's having a problem with the corrections. He's not able to show. So I'll request now Anshu Anand to give us some social message, and then we'll take Dr. Shokar and Dr. Satyen Singh. And Doctor from Pakistan, our friend, Dr. Mansoor Ahmad and other friend will be joining soon. So Anshu, please go ahead with the social message. She's a healthcare advisor and also business advisor. So
Sure.
Can you go ahead with the 3, 4, 5 minutes of your talks about that?
Sure. Can everyone hear me?
Perfect.
Okay, great. According to my study, which has been, according to the latest data, whatever is available, the sector is going through a severe crunch with, investment required in additional manpower, equipments, consumables, and others. And there's a loss of 14,000 to 24,000 crores that is expected in short term within this quarter, which is very concerning since there is a high, there is triple burden on the system, and there is low financial performance with less than 80% fall. And now to do this, we need liquidity infusion. We need, short-term interest-free, something like a concessional interest on loans or indirect tax benefits, rebate on commercial rate of power, because, everything is running on triple the cost than before. Apart from that, I think even the resources have become very difficult, which is causing stress to the system with the important raw materials that were imported for the finished goods to be produced here of medical devices have seen a lot of crunch in availability. So what we require is is a new way of looking at the industry. I think healthcare industry has never been so important in our recent memory, because the last greatest pandemic, there have been other pandemics, but they were fairly smaller in impact. So which is why I think, now we understand the pressure that the healthcare industry can face, and the importance of how, the robust system that is required in the healthcare sector, which now I think this should point the importance towards technology intervention, and specifically the use of deep technology, which is robotic automation, AI, and blockchain. There should be new standard operating procedures that are aligned with the disaster management. My concern is that this is this COVID-19 has come out of a virus which was not supposed to survive in humans. It is supposed to live in other species. And what is the guarantee that we have? Like right now, we don't have the guarantee of when can we eradicate COVID-19 from the world. Besides that, my concern would be an eruption of something of that nature again while we are tackling this. So in my opinion, I think we need to, I think the healthcare sector is, of course, overburdened right now with the immediate scenarios, but we need to focus on the business and the process improvement aspects so that we are better prepared to overcome this short-term burden and use that in the next in the future developments, because I think like any other recession that we have gone through, or a financial crisis that we have gone through, has been a V-shaped curve. There is going to be a sharp decline and right now, but there will be a spike in the demand, and in return, and we have to be prepared with the supply of resources, of people, and the knowledge to overcome the peak point. Any questions?
Thank you very much, Anshu, for a very kind. I would just one question. That means you think that the healthcare industry, because now investment is so much down. I mean, for the newcomers, will it be difficult to get the funds, or it will be not or the same, especially FDI or the banks in India? Very quick answer. Yeah.
Sure. So, from investors' point of view, be it I'm speaking in terms of the funds or the family offices or VCs, they are looking at their first priority is investing in companies which are in medical sector. In terms of loan, the public sector banks are still waiting for the latest policy framework, which was announced by the finance minister. But besides that, the rate of interest has considerably reduced for past 4 years. So I think raising funds for healthcare sector is the immediate requirement, and I think everybody understands, and people who are banking on return on their investments, they know that this is the sector which is going to grow big time. This is for the next 3-4 months, there will be a crisis in terms of trying to manage the operational losses, but after that this sector is set to boom. There is no doubt about that.
Okay, thank you, Anshu, for your kind words. And that means one should not be discouraged to start new setup.
Not at all. This is the time to convince people about business based in healthcare sector.
Okay, so let me take one quick comment from Ashrokan, and then we will take Dr. Satinder Singh and Dr. Abdul Rashid Khan and Mansoor Ahmed.
Good evening. We had an excellent discussion on myocardial infarction in COVID era. I think it's Dr. Robert has shared his experience from Africa, South Africa. And there's a difference in the treatment in USA versus other countries, and a certain part of Europe versus other countries. And now I think Dr. Mohan has clearly stated the view of CSI in these aspects. My question is regarding STEMI management during COVID era. We know that is STEMI with COVID, the mortality is up to the tune of more than 69%. So it comes with the STEMI with COVID. The only way you can reduce the mortality is to intervene and do intervention at the right time. So at the same time, we are worried about the cross-infection in the hospitals and to the health workers. This is a worry, how to tackle this problem. One way we have a pro-thrombotic stage, pro-inflammatory stage, and the same way the mortality is high if patient develops COVID in this situation. Second one is we see that there's a lot of STEMI patients coming to the hospitals and is coming down during this COVID era. So my question is there any increased trend, sudden death in the community during this period? Are we missing a lot of STEMI patients that's at home? Or are we going to get more of LV dysfunction in next few years because of late presentation and people are not getting treatment at the right time? These are the three questions.
I think you're right, because Dr. Robert Bathengi is also listening and Dr. Mohanan must be there. But you're right that I have a few known people who was COVID positive and they died during sleep, at least two of them. One was elderly gentleman, other was a young man who was not hospitalized. So the guideline for the government says that there is no need to hospitalize now because of the overwhelming requirement of the beds. Just now I received a call that they want to shift some patient from COVID-19 to our isolation ICU, which is full. So what I mean to say is that you're right that you may get more of a LV dysfunction patient because you might be missing. STEMI will not go down that much because although you are relaxing, but this is a plaque rupture, not only totally because of stress. So we all know this. Dr. Yashpal will also agree. And Dr. Mohanan, if he's there, then he can answer your question. Dr. Mohanan, can you put on the video or we'll take the question later on? So in the meantime,
I will do that. I can take the question now. No problem.
Okay, please go ahead because I cannot see you. Your video has to be on.
I think.
But we can hear you well. You can reply to Ashokan's question. That means we are overwhelmed and therefore, you can see. Please reply to his question. Then I'll take Dr. Satyendra Singh and Dr. Abdul Rashid Khan later on. And Dr. Mansoor Ahmed.
The problem is, as I mentioned, all of us know the logistics of doing a primary PCI in every COVID is the problem. See, if you are trying to do every case with a PPE for all the persons inside the cath lab, dedicated cath lab, how many of us can afford to do that? Among the 1,200 cath labs in the country, only about 15 to 20% of them have a twin cath lab. All the others are using one cath lab. So practically that is not, if you are dedicating cath lab for STEMI intervention, that too in an uncertain STEMI, is a major problem. That was the main reason why when we formulated the consensus statement. Even though we know that the 30-day mortality between a primary PCI and a lysis patient are different, but the logistics say that. That was the reason why we said that now if the hemodynamic impairment is there or is a high-risk STEMI, every high-risk STEMI has to be with the sufficient PPE attempt PCI. That is the reason. I mean, it is not the, I agree with the slogan that it is absolutely, that's why the Americans and the Europeans prefer the sky statement PCI only. So,
okay, I understand your.
What was the second?
Your voice is not very clear. It's breaking. I think you have to increase your bandwidth next time.
Vivek, we can't hear the voice properly.
Yeah, we can't hear the voice because your bandwidth is too low. I think you stop the video, then you can reply. Maybe it's better voice. Please quickly do that.
That's better. I will cut my video.
Yeah, maybe then. Yeah, please quickly reply in 1 minute, please. 1 or 2 minutes.
The logistics of doing a primary PCI in India is the one which decided for us to keep lysis as the default strategy, even though we know primary PCI is much better. It gives you an added 6% mortality advantage. But the fact that out of the 1,200 cath labs, only 10 to 15% has 2 cath labs. And you have to have at least 2 cath labs if you decided to go do a primary PCI. And the attended cost of PPE for the entire cath lab staff is another added thing. That was the main reason. It is not, I do agree that the best policy is I will not agree with Dr. Yashpal's comment that everybody should be doing a thrombolysis. No, at least the world data, every data has shown the SKY recommendation, the ESC recommendation, as all said, do a PCI if possible with sufficient personal protection.
Quickly, Dr. Reshpal, please, very quick. I cannot unmute you, unfortunately. I think
He's unmuted. We can't hear him.
yeah, we can't because I'm not able to unmute him, unfortunately. It's muted. Okay, we'll take Reshpal later on. So we have a Dr. Abdul Rashid or Dr. Satendra Singh wants to speak something. Please, quickly. Yeah, he has a question. He's an orthopedic surgeon, my class fellow from Bareilly and very senior person with many hospitals. So please, Satendra Singh, please go ahead.
Thank you, Vivek. You are doing a very good job for the, I think, last 2 months continuously. And more the information we get, more we can plan. My question is, at what stage in India we are? And when you expect, because your prediction is very correct always, when you expect that we will reach the peak of this disease and when it will start decline? That's my simple question.
I think I will answer myself. We have not reached the peak. I showed you in the slide that the curve is still going up. We are not able to predict this. I think when I made a tweet to Honorable Prime Minister about a week back that we need to continue lockdown, because lockdown is a good solution. But unfortunately, because the economy, all the chief ministers have taken this different stand and they started making working people to go over the trains and all. Everybody will not be wearing the mask or something. I know that sometimes the photographs are looking like that everybody is using it. So this is a very dangerous situation. I think we have to find some special package from the government so that we can start feeding the people who are really worse affected than us. And then stop 2 months more lockdown minimum so that we stop moving here and there. Otherwise, unless the vaccine is there, the things will be very dangerous. Or we have some medicine which will be actually working. You heard that America, the few states are going up and few states are going down and they're opening up. Or else we see, जैसे कि मैंने हिंदी में बोला था, जियो या मरो, लेकिन काम करो. But we cannot do like that. We cannot do like that. This is only just a statement. So we have to be very, very careful. The next few months will tell us. But India is not going to slow down. I think we have to be, our central government has to be more strenuous and stringent, passing orders to the chief ministers not to open the lockdown till we are actually flat. We are doing the less testing now, and we are doing the less testing as compared to the America or Europe. So with the less testing, also the flat is not curving. The curve is not flattening. Okay, so I think we have to move on. Dr. Yashpal Sharma wants to come in, but I am not able to unmute.
Thank you very much. Thank you.
So Satendra will have one of your song in the end. So I will take now Dr. Mansoor Ahmed or Dr. Abdul Rashid
Hello.
Yes,
can you hear me now?
I can hear you, but I cannot see you.
And
From Pakistan. I have to unmute everybody and then mute. So let me have Dr. Rashid Khan. Dr. Rashid Khan, I cannot see you. No, you have to put your video.
Now can you see me now?
No, not yet.
Hello.
Yeah, I can hear you, but I cannot see you.
Can you see me now?
No.
Thank you.
You can speak. You can speak. I cannot see. You have to put on your video. I think we go ahead with Dr. Mansoor Ahmed. Yes, I can see Mansoor and I can see him very well. He's also from Pakistan, Karachi. He's a former head of department. So I'm unmuting you. Mansoor, are you Mansoor? Mansoor, there's some problem in the audio. I cannot hear you, although you are not muted. Can you hear me? So in Abdul Rashid Khan, we were not able to. In the meantime, yeah, Abdul Rashid Khan, you're back. I can see you now.
Can you hear me now?
Yeah, perfect. Please go ahead. We can see
Hello,
you.
hear me?
Yeah. Please, quick comment from Pakistan, please.
Thank you very much, Dr. Gupta, for arranging this. I just want to have two comments. Number one, the use of hydroxychloroquine. You know that today France has banned the use of hydroxychloroquine in the treatment of COVID because of the morbidity. So I would like to know your opinion, because you are the most expert in that one, and you are always quoting that the hydroxychloroquine should be used as a prophylaxis as well. My number two question would be, should we have PPE in OPD as well, as we are seeing the suspected cases in OPD? Because in the OPD there's a lot of humid climate, and really people are inside. So my question would be to anybody: should we need PPE OPD as well, and how the hydroxychloroquine usage as a prevention or the treatment of COVID-19?
First question I will answer. Second question I will let Ashokan to answer. The first question regarding hydroxychloroquine.
Yeah.
What is happening is that hydroxychloroquine has been abused by initially Americans only, and there was I feel there was a tight war against Donald Trump. You see, initially China said it is very clearly indicated, and they found the real utility in patients of COVID. I'm talking of treatment. I'm not talking of prophylaxis. Later on, it was confirmed by French, 1,000 patients, only 0.4% mortality. Then third came again America. America came up with a sort of a not the guideline, but an article which was published, and that was April end. And they said it is not useful. It is in fact increasing the mortality in COVID. We were not talking of prophylaxis. I'll come back to prophylaxis later on. Then the Lancet article, you told that France has also banned. So WHO only day before yesterday has stopped the trial which they were doing for COVID patients. Only on the basis of the Lancet article. I went through this article completely. It's a huge article. I think everybody should use it. They have seen a prospective analysis of COVID patients treated by hydroxychloroquine, about 25,000 patients. And of that, the majority are basically elderly with comorbidities. And they found, and this was given indiscriminately, that means without checking the heart status, without checking the QT interval, and they found there was increased mortality. So on the basis of the Lancet article, you see the pitfalls, you see the limitation of that article is very well written. The limitation was that was given indiscriminately without checking the heart, without checking the QTc interval. So on the basis of that article, the France, as you said, has banned or rather said that you should not use it in COVID patient. And similarly, the WHO has stopped the trial. But I would say it's a fight between WHO and Trump. The ICMR guidelines still today in India, when you have no drug, why can't you use it discriminately? You see the ECG, you see the myocardial functions. It is not that dangerous. A lot of rheumatologists are using day in and out hydroxychloroquine. It is not toxic that much. People have made an unnecessary. For prophylaxis, another statement came only yesterday by Director General, no less than Director General ICMR, clarifying that we are still allowing and approving as a prophylaxis to all the healthcare workers and those, but I am extending it to the field worker also. So in the absence of anything which can be preventive, a safe drug, I would say still a safe drug, it's not toxic drug, of hydroxychloroquine should always be taken. I told you that we have one consultant who was taking hydroxychloroquine, despite that he got infected. So hydroxychloroquine does not prevent infection. It will reduce the virus load. You will not become bad. That means you will not become severe. So that is the way I am taking it. I forgot to ask Gregg whether he is taking it or not. All healthcare workers, this is my thing. Second question regarding regarding the PPE in the OPD, let Dr. Ashokan or Dr. I'm not able to unmute, unfortunately. Yashpal wants to speak a lot. Yashpal, you are muted by the computer. Okay, now you are unmuted. Dr. Yashpal, please answer his question. Now, specifically question, PPE in OPD. Don't talk about thrombolysis now. We'll talk about the PPE.
Dr. Vivek, basically I'm seeing a lot of questions on the screen also that I will tell regarding PPE. If patient status is not known, if there are no barriers, nothing, then PPE. If you are taking all precautions, barrier and this one, then PPE may not be indicated. DRDO has made this one that in your OPD you make a parachute barrier and then sit across that. Then PPE may not be needed. But if there is none and you are in direct contact with the patient, PPE may be preferred, because at this stage nobody knows how many patients got infected come in OPD, because we are not having any kit test or any. We in PGI are developing a card score which will be this one, so that we can see how much probability of the patient is to have COVID, and then we will do other. There were some questions. But etiopathogenesis, as I already told, that it was a endothelial dysfunction thrombosis, and by the time there was no virus, there was superadded sepsis. Basically, see, the WHO has said that sepsis should be treated early. Asymptomatic bacteremia, which was there, which we were treating and telling that sepsis should be treated early in cardiac patients. They do not give time. If you start antibiotics from the very low dose and all this, by the time the patient is up. So if you treat the sepsis early and monitor them very closely, we are writing to WHO as well as to the United Nations letter regarding antibiotics that is ready, because we from the very beginning were saying that for immunocompromised patients and other patients, treat sepsis very early. So WHO used to say that no, you don't give antibiotics. That was general, not for immunocompromised cardiac patient with other problem. How much they go into septicemia and ARDS. All things are because of this. If you treat them early, no ventilator will be required. Nothing. Patient will be treated and they will go home very fast. If sepsis is there, then ARDS, multi-organ dysfunction, patient on ventilator for months, and the whole of ICU gets this one. You have experience, and I was discussing with you recently regarding one patient. How much sepsis is important, how much hemodynamics, IABP, and other drugs are important. We gave iron. Iron is a patent of India, and the whole of the world is now treating heart failure, valve. Earlier, these patients were going for transplant, for valve surgery, and they are being treated just with the iron and other treatment. So you know very well, in every conference I have told, these are our patents. Nobody can stop that. We cannot treat that. We have all this CTO first, CTO last. That we always used to do CTO last. We always said culprit only, not culprit. US is following now those protocols, which we were following for the last 10 years. So basically, it is not in that way. It is a concrete this one, but we learn from each other. But blindly we should say that no, double-blind, randomized studies are needed. Randomized studies after 10 years, meta-analysis say nothing is there. We always see when meta-analysis are.
I think Dr. Gregg Stone's view that randomized. Okay, thank you very much, Ishpal. And I think Satyen wants to come in again. Please, quickly, yes.
My question is to Dr. Yashpal and all. As you were talking about parachute, so there are so many loopholes in this parachute. Firstly, patient comes in contact of our employee, and at so many times we don't have any parachute there. Our employee who is taking the temperature of that person from 1 meter distance or sometimes from less, and he is coming in steps to us. We are sitting in a safe zone, but unfortunately that our employee is not in the safer zone, and we are in regular contact of that employee. So at this step, this parachute doesn't work, sir. What is your opinion, sir, again?
Yeah, I agree that in that setting, if by chance you can prefer PPE kit, because to be very safe, because this is a time where safety is most important. In PGI now we are doing teleconferencing OPD and this one consultation. So we have not started OPD. So basically now tele-emergency we are also telling that
Yes.
patients will be taken after with appointment with all precautions and their history. Maybe tomorrow test is available, then patient will come with test. But test has a specificity of 60% only. We cannot go up to 90. If we add CT also, for which we are working as a modality, that patient comes with the CT and test later on. You don't know what is going to happen because healthcare worker, doctor, they are most affected. You see in the tributary from Europe, everywhere. The doctors, healthcare workers are at risk.
Yeah. I just wanted to
You
share.
mean to say we all, sir,
Should we-
please, you mean to say we all should wear personal protection equipment, including our employee. If he is not wearing, he is at risk. We can be at risk.
No, Satyendra, I would say that it's better to use for ourselves PPE. The employee may not be using it, but if you are protected yourself, it's better. Yesterday, I want to share one thing. I went to the changing room of cath lab. Yashpal, just listen to me. I went to at 10 or 11 p.m. I went to change my dress, and I found one PPE kit which was used by somebody else of my colleague to go to the ICU, was lying on the floor of the changing room. So I was myself very much surprised, but at that time I did not give much importance. Later on, I thought this PPE kit has been used and gone to the COVID ward, is lying on the floor of the cath lab Apollo. It can infect anybody. So this is very important. People who are wearing PPE kit has to be actually, it goes away somewhere where it is incinerated. So this happened yesterday in Apollo, that's why I want to share. Okay, I think we next move on to somebody else before we take up the songs. Yeah, I think Dr. He wants to come in. Please introduce yourself.
Yeah, Vivek.
Yes.
Can you hear me?
Yeah, perfect.
Yeah. I am Dr. VK Shah. So I take.
Sorry, VK, you are looking like a pilot, captain.
So Vivek, I take pride. I take pride from coming from Mumbai, the financial capital of the city. Of the country. But for those people and our foreign guests, let me introduce them to Mumbai. Mumbai is like a cluster of slums. It is a slum city in which there are some oases in between, scattered, in which we live. And therefore, it is so intensely, densely populated that the concept of social distancing has taken topsy-turvy. And when the first case of COVID was identified in Dharavi, which is the largest slum in Asia, the future of Mumbai was written on the wall at that time. Currently, today, Mumbai is the epicenter of coronavirus in India, with more than 60,000 patients affected with it. More than 1,500 people have expired because of that. Though the recovery part is also very good, 20,000 patients have recovered from coronavirus or COVID. But alarming fact is that still we see a daily increase of new cases in an alarming proportion. I must congratulate the government at this stage for implementing the lockdown very, very seriously and severely. Otherwise, I don't know where these numbers would have gone. The city has been crippled and the country has been crippled by the economy. Millions of migrant workers who had come to Mumbai for their livelihood have lost their jobs in this pandemic and rendered jobless and had to return back, which was a very, very sad thing. Most of the people in private sectors in Mumbai, like private enterprises, malls, restaurants, have all been rendered jobless and haven't returned. So this COVID-19 has taken a good toll not only on the people of Mumbai but also on the healthcare workers. Many of these healthcare workers, including doctors and people working in the hospitals, have been affected. And most of the hospitals today, Vivek, in Mumbai, are working barely on skeletal manpower. In most of the Cardiac patients, we have medical management only possible. Most of the cath labs are not functioning, barring a few in Mumbai, and where also the choice of ST elevated MI to do is by thrombolysis only. Only when that patient remains unstable after thrombolysis and medical management, then only he is taken up for angioplasty. The reason for not taking these patients for angioplasty is also because the healthcare workers have got inertia to go for it without COVID test. Cost of the treatment has also increased for the patient, as well as because of the isolation, sanitation facilities, use of multiple PPE for various people, and the blood test done. What we have seen in Mumbai, the incidence of acute MI reaching the hospitals have decreased, but that doesn't mean that the patients are not having MI. Maybe it is still more, because corona is ultimately an inflammatory disease, which will cause an underlying plaque which was dormant, may rupture and produce a thrombosis and an acute MI. So I don't think actually that the incidence of acute MI is reduced, but people are reluctant to come to the hospitals, probably because of fear of corona. Probably they are not able to reach the hospital because of lack of services, or probably not getting enough transport facilities. And what I have wanted to see in my practice, I have seen that apart from ST elevated MI, I have also seen a couple of patients who had myopericarditis presenting as chest pain, and ultimately we could diagnose when we did a bedside echo to see that he had a pericardial effusion. Patient was treated for that and went home safely. So these are some of the things that I feel that cities like Mumbai, which is the financial capital, city where Bollywood stars and big industrialists live, has been crippled to its worst possible effect ever that we have seen in the last century, probably.
Thank you very much, VK, for giving thought process about Bombay, because we were looking forward to hear it. And your chief minister, the new chief minister, the first time chief minister, is having a major trouble to control it.
But he has done a good job by intensifying the lockdown, But that's not the only thing that can help,
Yeah, that's what I was saying, that lockdown easing is not the right time. So maybe now we can have few songs and then we can have a closing comments, because Pankaj Jeswani, are you ready? Pankaj? Okay, then Satinder, Dr. Satyendra Singh? Yeah. Sorry, I'll just have to wait for the people. Any comment from Ashokan before we start this song process? So, okay, Satyendra, would you like to sing some song now? Before our Pankaj Jeswani comes in. And Rajiv Yadav, I would like you to speak something little from Agra later on.
सर मैं तो आप लोगों को बढ़िया तरीके से सुन रहा हूँ, बाकी तो कोविड के बारे में.
Retired policeman, very aggressive police person from a good friend from Agra, and but okay, thank you so much. Satyendra, can you hear me?
Yes.
Okay, please one song and then we'll have Pankaj Jeswani, and then Anshu, please wait for a while. We'll have a closing comment in the end.
2-4 lines on your request, please.
Mohammad Kutubuddin, let me introduce. He's from JNU and he had some questions, so he can have a final comment later on when we close the session. Okay, so Satyendra, please go ahead.
मौसम ऐसा है ना, ये अंशु जी ने कहा होप रखिए, और होप हो नहीं पा रही है. पुराने अस्पताल चलाना मुश्किल है, नया कहाँ से खोलेंगे मैडम?
नया खोलेगा. चलो ठीक है. Okay, please go ahead.
कहाँ तक ये मन को अंधेरे चलेंगे. पॉजिटिव सॉन्ग है. उदासी भरे दिन कभी तो ढलेंगे. कहाँ तक ये मन को अंधेरे चलेंगे. उदासी भरे दिन कभी तो ढलेंगे. कभी सुख कभी दुख यही जिंदगी है. ये पतझड़ का मौसम घड़ी दो घड़ी है. ये कोरोना का मौसम घड़ी दो घड़ी है, नए फूल कल फिर डगर में खिलेंगे, उदासी भरे दिन कभी तो ढलेंगे। ठीक है विवेक, आप शुरू करिए। थैंक यू।
Thank you. I am now taking our celebrity international singer, Mr. Pankaj Jeswani, but difficulty to something wrong with the Zoom system. When I try to unmute, it is not getting unmuted very quickly.
No, it's asking us to unmute.
Yeah, okay. Pankaj, please come. Please come. Pankaj Jeswani sahab, how are you? I'm a good friend. He comes in the last minute. I requested him just 1 hour back.
Fine, sir. आपको आवाज आ रही है?
Yeah, please. मैं सुन पा रहा हूँ आपको. Yes.
आवाज आ रही है?
बिल्कुल आ रही। किशोर कुमार के और मोहम्मद रफी के 1-2-3 गाने सुना दीजिए, थोड़ा सा दिमाग फ्रेश हो जाएगा।
अच्छा, रफी साहब के आज आप चाहते हैं गाने?
यस यस, आप ऐसा करिएगा, एक-एक स्टैंजा सबका लेते जाइए, रादर देन गिविंग फुल सॉन्ग, 1-2 स्टैंजा के 4-5 गाने, 6 गाने हो जाएंगे।
मैं वही करने लगा हूँ, कुछ गीतों को जैसे हर बार करता हूँ मेडले बना के, लेकिन एक ये गीत बहुत ही अच्छा है जो दिल के करीब है। मैं चाहता हूँ, आपने रफी साहब का जिक्र किया है, बहुत ही उम्दा सिंगर हैं और वैसा आवाज आज तक आई नहीं है। भाई मौसम की बात चल रही थी कुछ, तो मौसम पर मुझे याद आया, मौसम बड़ा अच्छा हो गया है। कहते हैं मैंने जिस दिन से न पीने की कसम खाई है, मैंने जिस दिन से न पीने की कसम खाई है, क्या कयामत है उसी दिन से घटा छाई है। क्या करें सर, लॉकडाउन में घरे बैठे हैं, है ना? तो ये सुंदर सा गीत बहुत मेरे दिल के करीब है। मैं चाहता हूँ आप इसको सुने और आशीर्वाद दें इस गीत को। ठीक है सर? म्यूजिक लाउड हो बता दीजिएगा, क्योंकि ये
नहीं परफेक्ट, शुरू करिए आप।
म्यूजिक लाउड हो बता दीजिएगा, आज मैं ब्लूटूथ पे नहीं गा रहा। इससे म्यूजिक आया?
यस यस,
ओके। दर्द दिल का पता न था मुझे, आप किस लिए मिल गए, मैं अकेले यूं ही नज़र में था, मुझे आप किस लिए मिल गए, मुझे दर्द दिल का पता न था, मुझे आप किस लिए मिल गए। यूं ही अपने सफर में गुम, कहीं दूर मैं कहीं दूर तुम, यूं ही अपने सफर में गुम, कहीं दूर मैं कहीं दूर तुम, कहीं दूर तुम, चले जा रहे थे जुदा जुदा, मुझे आप किस लिए मिल गए, मैं अकेले यूं ही मजे में था, मुझे आप किस लिए मिल गए। न मैं चांद हूँ किसी शाम का, न चिराग हूँ किसी बाम का, न मैं चांद हूँ किसी शाम का, न चिराग हूँ किसी बाम का, किसी दाम का मैं तो रास्ते का हूँ एक दिया मुझे आप किस लिए मिल गए मैं अकेले यूं ही मजे में था मुझे आप किस लिए मिल गए मुझे दर्द दिल का पता न था मुझे आप किस लिए मिल गए थैंक यू सर फॉर इंस्पायरिंग मी
दो तीन गाने मिक्सअप करके दो स्टैंजा
आपको मिक्सअप
बहुत बढ़िया
बहुत सुंदर सा मेडले में लेके आया हूँ शायद पहले कुछ ज्वाइन किया होगा इसमें कुछ मैंने कुछ नए गाने इसमें जोड़ता हूँ इसमें आपको तरह तरह के सिंगर्स के आवाजें मिलेंगी वैसे मैं अक्सर एक क्विज पढ़ता हूँ लेकिन यहाँ टाइम नहीं होगा आपके पास का पेन निकालें और बताएं कौन सा गाना किस सिंगर का है अगर बता सकते हैं तो बड़ा आनंद आएगा
अगली बार नेक्स्ट टाइम
म्यूजिक के शौकीन रहते हैं एक एक लाइन सुनाऊंगा फिर बताइए कौन सिंगर है अगर मेरी वॉइस आपको अच्छी लगे
चलिए ठीक है ओके
बहुत क्रिस्पी रहेगा ठीक है सर मैं शुरुआत करता हूँ सुंदर से नगमे से बताइए क्या सिंगर का नाम क्या है बहुत यहाँ मुझे मालूम है डॉक्टर्स बहुत गाते हैं तो जलने दे मासूम बहार याद न कर दे जलता है तो जलने दे
गाया तो मुकेश ने लेकिन आवाज उनकी है नकल करी है केएल सहगल की
बहुत सही कह रहे हैं सर आप बहुत सही पकड़े हैं आप पहले जो गीत है पहले मुकेश साहब सहगल साहब की आवाज नहीं गाते थे आए तो हीरो बने थे
अच्छा सत्येंद्र हमारे म्यूजिक के शौकीन है इन्होंने पकड़ लिया मैं नहीं पकड़ पाया मैंने सोचा केएल सहगल नहीं गाया है
नहीं सभी लोग पहले ना केएल सहगल साहब को इमिटेट करते थे चाहे पंकज मलिक साहब हो चाहे चीफ हो चाहे सुरेंद्र हो चाहे मुकेश जी हो चलिए ये गीत देखो
सबको अनम्यूट कर दो इसमें ना सबको अनम्यूट करो तभी तो वाह कर पाएंगे लोग अब सबको अनम्यूट कर दो
कर रहा हूँ टाइम प्रेसेस
को म्यूट कर दे महफिल बन जाएगी आनंद आएगा
जी हाँ अब मजा आएगा ना
योर रिएक्शंस कहते हैं ना मैं गम की दुनिया को छाती पे रख के जीता हूँ बुराई तो ना पीना में बुराई तो नहीं मैं गम की दुनिया को छाती पे रख के पीता हूँ जिंदगी में जवानी को लुटा के पीता हूँ कि लोग तो पानी मिला के पीते हैं और मैं तो आपसे निगाहें मिला के पीता हूँ प्यार मेरे जीवन की खुशी देती है खुशी कई गम भी मेहमान भी हो मेहमान भी लो कभी बात तो मनना ये नयन दरे ये जाम हरी हरी जरा कल की किसको खबर कौन सिंगर थे सर
क्या बात
सिंगर का नाम बताइए अच्छू जी बताइए
ये नयन डायरेक्टर है
हाँ मुकेश जी होंगे नहीं हेमंत कुमार
हेमंत कुमार
का गाना और सुनिए एक लाइन अपना दिल को आवारा न जाने किस पे आएगा
सही बताया विवेक ने हेमंत कुमार सही बताया विवेक
हेमंत कुमार ठीक
ओके नेक्स्ट करिए
अंशु जी यशपाल जी और मैडम बैठी हैं अच्छा अंशु
मैडम भी गाना गाए ना एक मैडम भी गाना गाती है
नहीं वो शी बिजनेस एडवाइजर
अच्छा
ये बताइए सिंगर कौन है
गाना गाती है क्या प्लीज सिंग सॉन्ग नहीं ओके अब इस लिसनर में है चलिए
ऐसा लग नहीं रहा है, गाती होगी वैसे आप।
कह न सके तो अपनी कहानी, तेरी भी पंछी क्या जिंदगानी, फिर तेरी कथा लिखी आंसुओं में कलम डुबोए, तेरा दर्द न जाने को, तेरा दर्द न जाने को। ये बहुत अच्छे सिंगर हैं सर, इनके बारे में बता देता हूँ क्यों। देश का सबसे बेहतरीन गीत जो आज तक है "ऐ मेरे वतन के लोगों", इन्हीं का लिखा हुआ है। और संत शिरोमणि मिली है इनको, संत कवि प्रदीप जी। बहुत कम गीत हैं लेकिन देश पे ऐसे लिखे गीत आज बहुत खरे होते हैं। ये 2 लाइनें सुन के बताइएगा डॉक्टर साहब, ये 2 लाइनें मत खेल जल जाएगी कहती आग मेरे मन की, मत खेल मत खेल चल जाएगी कहती आग मेरे मन की, मैं बंदनी पिया की संगिनी हूँ साजन की, मेरा खींचती है आंचल, मेरा खींचती है आंचल, मन मीत तेरी
हर पुकार,
मेरे साजन है उस पार।
ये तो R.D. बर्मन के पिताजी का गाना है।
क्या बात है सर, आप तो पिताजी तक पहुंच गए उनके। सही कह रहे हैं, पहला फोन उन्होंने किया है, ये S.D. बर्मन साहब हैं, बिल्कुल ठीक। और सही कह रहे हैं सर, मैं जान वही गा रहा हूँ, आपको मुझे मालूम है, इतनी नॉलेज है। एक सिंगर और बताइए। आपके करीबी सिंगर है, बहुत अच्छे मुझे लगते हैं इनके गीत भी। चिंगारी कोई भड़के तो सावन उसे बुझाए, सावन जो लगन लगाए उसे कौन बुझाए, उसे कौन बुझाए। ये तो सिंपल है सर।
और लोगों को बताने तो मैं तो बता ही दूंगा।
ठीक है सर।
यशपाल जी बताइए। मोहम्मद कुतुबुद्दीन।
अमर प्रेम का गाना है, कोई बता देगा, राजेश खन्ना के ऊपर गाया गया।
क्या राजेश खन्ना के नाम से पता नहीं चला कौन है।
गुड इवनिंग सर।
गुड इवनिंग कुतुबुद्दीन, बताइए गाना किसने गाया है?
सर मैं कुछ सुनाना चाहूँगा। सबसे पहले शुक्रिया अदा करता हूँ प्रोफेसर विवेक गुप्ता जी और अंशु जी कि आपने हमें इसमें शरीक होने का मौका दिया। और ये जी, मैं JNU में यहाँ अरेबिक सेंटर में एसोसिएट प्रोफेसर हूँ अरेबिक लैंग्वेज का। और मैं ये आपकी ये मीटिंग 2 मानों में बहुत ही इम्पोर्टेंट है। एक तो ये कि आपने हार्ट डिजीज से रिलेटेड उस पर क्या इम्पैक्ट हो सकता है कोविड-19 का, वो भी है। दूसरा ये कि मनोरंजन का भी अच्छा खासा इंतजाम आपने रखा है। मतलब ये कि दिल और
पिछली बार अनु मलिक आए थे।
फिलहाल तो किशोर कुमार ने गाया था, ये बता दें उनको बीच में।
बता दें सर, एक गाना फिर और सुनाता हूँ।
नहीं, ये कुछ सुनाना चाहते हैं, कुतुबुद्दीन भी सुनाना चाहते हैं। You want to sing something?
Yes, I want to say something.
हाँ बोलिए, जल्दी बोलिए।
जी, मैं 2-4 लाइन सुनाना चाहूँगा। कोविड-19 से जो लोग लड़ रहे हैं, जो उसके वॉरियर्स हैं, उनके लिए। अभी 2 दिन पहले JNU मैंने ऑनलाइन मुशायरा ऑर्गेनाइज करवाया था। एक शाम कोरोना वॉरियर्स के नाम, तो उसमें कुछ शायरों ने शेर पढ़ा था। उसमें यह है, मुलाजा फरमाइए कि सरहदों से अस्पतालों तक जो कर रहे हैं खिदमत खल्क, सरहदों से अस्पतालों तक जो कर रहे हैं खिदमत खल्क, उनके जज्बे को सलाम, उनकी हिम्मत को सलाम, उनकी गुमनामी को सलाम, उनकी शोहरत को सलाम, लड़ रहे हैं जो वबा से, उनकी अजमत को सलाम। मुसीबत की घड़ी में जो खड़े हैं सीने ताने, उनके तदब्बुर को सलाम, उनकी हिकमत को सलाम। ये सब समर्पित है आप डॉक्टर्स के नाम। थैंक यू।
बहुत अच्छा सर, नेक्स्ट टाइम मुझे बुलाइएगा, मैंने बहुत लिखा करो वहाँ पे, मैं गीत भी लिखता हूँ। मैं
अभी आप थोड़ा सा और एक दो गाने और के बाद then we'll finish and last comments।
हाँ जी, ये गीत बताइए किन्होंने गाया है?
किशोर कुमार ने बता दिया।
किशोर कुमार बता दिया सर। बहुत अच्छा बताया आप। थोड़ा सा मुश्किल पूछूं सर आपसे? ये थोड़ा मुश्किल सा बताइएगा। तेरे दामन से जो उन हवाओं को सलाम, उस जुबान को जिस पे आए तेरा नाम, सबसे प्यारी जुबान तेरी, सबसे रंगीन तेरी शाम, तुझ पे दिल कुर्बान। मेरे प्यारे वतन, मेरे पिछड़े चमन, तुझ पे दिल कुर्बान।
अन्ना डे।
यस,
देशभक्ति की बात की आपने।
प्राण मनोज कुमार की मूवी थी।
ये बात बताइए, ये आवाज तो माइक की जरूरत नहीं थी, आवाज ऐसी थी जिसको माइक की जरूरत नहीं। मैंने माइक हटा देता हूँ डॉक्टर साहब, जरूरत नहीं माइक की।
नहीं, मजा आ रहा है माइक से सर।
ये बिना माइक का। कितने जलवे फिजाओं में बिखरे मगर, मैंने अब तक किसी को पुकारा मगर साथ देने का वादा करो, मैं यूं ही मस्त नगमे लुटाता रहूं, तुम मुझे देखकर मुस्कुराती रहो, मैं तुम्हें देखकर गीत गाता रहूं। महेंद्र कपूर।
यस,
किसी माइक की जरूरत नहीं थी।
मेरी थोड़ी बहुत मुझे भी नॉलेज है।
दोस्त किसके हो यार? और तुम्हारे स्टंट हमारे पड़े हुए हैं तो चल रहा है ना हम लोग।
सतेंद्र सिंह के 4 स्टंट मैंने लगाए थे, but he still not stop smoking.
ये तुम जरूर बताते हो।
It was done about 5 years back, Satin.
No, 7 years, more than 7 years.
So the stents are working fine. That's why you are singing and you are doing operations of orthopedic surgery.
It's just because of you, yaar.
And we should finish. It's already too late. Night, more than 2 hours have passed. Any final comments we'll take from everybody before we finalize the thing. So,
कहें तो ये सुंदर सा गीत आप सब।
अरे जरूर।
Okay, please go ahead.
इस गीत की।
म्यूजिक बढ़ा दीजिए।
कौन हो दुनिया में ना पाप किया जिसने, कौन हो दुनिया में ना पाप किया जिसने, बिन उलझे कांटों से है फूल चुने जिसने, है फूल चुने जिसने, बेदाग नहीं कोई यहाँ पापी सारे, ना जाने कहाँ जाए करते तुम्हारे, संसार दुख सुख तो किनारे, ना जाने कहाँ जाए हम बहते आए हैं हम बहते आए हैं हम बहते आए
ओके, थैंक यू वेरी मच पंकज जी, आपने मजा ला दिया, क्योंकि ऐसा होता है ना, ये बड़ा स्ट्रेसफुल काम होता है और स्ट्रेस को आपने रिलीव कर देते हैं एंड में हमारे दोस्त सत्येंद्र सिंह के साथ में. आई थिंक वी हैव ओनली वन कमेंट कमिंग फ्रॉम Yashpal, and then we will finish off. Dr. Yashpal, just final comment about the program and overall overview of COVID, and then we'll take one comment from Anshu Anand and myself, and then we'll finish off.
I think Dr. Vivek, this was an excellent program you managed. In fact, your earlier webinars were so informative, and I think these are giving a good information to the whole of the globe, in not only for India, or even other countries. Basically, as you said, the peak can come in India. So we have to be very, very careful at this time and plan ourselves for everything, because that will be our smart way of working, that we got time. But definitely for healthcare worker health also, we should keep in mind that how they manage their work level, their stress level, everything, because healthcare workers are also to be protected. We have to do for field worker, healthcare worker, patients. So basically it is an integrated approach so that we can manage. But you had a very good meeting.
I want to ask you, every day my parents say they don't go to hospital. I'm still coming. I have not even a single day off, despite the lockdown, despite the risk. And our hospital is having 87 beds of corona. And there is one ICU corridor where the suspect patient also crosses the CCU, and we all are scared at that time. So what do you advise, that should we stop coming to hospital for some time, do only video conferencing, stop hospitals? What is your strategy in PGI Chandigarh? Very quickly.
No, we are going to hospital. In fact, the thing is, even during lockdown, we were preparing for the emergency. We have present time, we have only emergency. So that is a
50% of Apollo senior consultant or 70% are not coming. I am one of those that I would say that when Prime Minister Narendra Modi says that he has not taken a single leave, I would say I am one of those senior consultant in a Delhi Apollo, not even a single leave during last 25 years, 20 years or 18 years. So even despite this, I'm little more, I would say that every day I'm warned by my family that please don't go, only start working, do webinar, don't operate, don't do, but somehow I feel that we should keep working with full protection. And this is my message to Satyendra also. Satyendra Singh says he has not operated for last 2 months. So a lot of people are actually not doing it, but it's a very difficult situation for all of us. That protection is not the only thing you can, despite protection, you can have corona.
Vivek, this time is very, very important. I just 1 minute, because for elective cases, we should not, during this time, elective cases should never be done, as it is always a practice that elective cases should be postponed. Their importance should be given to the emergency patients, COVID positive, COVID negative.
Would you come to hospital or not? This is my question.
Yeah, we are going daily to the hospital, even during lockdown. That's what I'm telling you.
But I tell you, 75% of Apollo consultants are not coming. 75% of senior consultants Apollo are not coming, or they're coming only for half an hour and then going away. I spend about 8 hours a day. Okay, so that means it's a personal call. One should take full precautions with PPE. Yeah, Satyendra, please come very quickly. We're getting very late.
A doctor with diabetes, with stenting like me, whether he should go to the hospital or not.
I think you can go to the hospital, but you don't, because orthopedic surgery, you need a lot of drilling. And therefore, you never know that virus can come. And then we have seen, I remember one patient from South Korea, one doctor from South Korea or Italy, he was telling that orthopedic surgeries are completely banned. Don't do surgery, but you can attend to OPD. Attend the OPDs with a face mask, shield. We have the shield like this. I'll just show it to you.
Yes, I am. Yes.
This is the face shield we are wearing. Yes. So this is the face shield. With the face shield and the mask, you can attend the OPD. This is my suggestion. Okay.
Sir, because in orthopedics, there are chances of gloves may rupture at times. A lot of power is required in putting and all.
Dr. Mathenge, are you attending to your duties these days? He's from Kenya.
Yes, what we've done is to, of course, modify very carefully, making sure that patients are properly screened and that we wear basic PPE, even for routine traditional examination of patients. And also we're only doing, for instance, in the cath lab, only urgent or emergency cases. We're not doing any elective work. Even elective treadmills, ESTs, we are deferring. So in other words, we are taking as much precaution as possible. And the reason is we have seen what has happened in the rest of the world. And this is coming to us a little later. So we are able to learn. And this is why, if you may allow me to make my final comment at the same time. This is why the webinars are important, because the disease is moving. So people, where it is coming later, we don't have to suffer the same fates. We now know how to protect ourselves better. And even more importantly, I can identify today with the feelings of some of the people in your country, particularly in Bombay, where the trend of disease, we are seeing it go to the slums, like you talked about it, and we are a bit worried. And secondly, the approach of only taking to the cath lab only those people who either for rescue angioplasty or those who are unstable is what we feel is safest, because we are not sure, we don't understand this disease. So thank you again very much. I enjoyed the music. I didn't understand the words, but the language of music is universal. My wife gave me to look, I heard there was a cardiology conference going on, but now there's music. So this is unusual. So this is unusual and very unique. And thank you again, Vivek. And we'll keep in touch. And thank you, everybody. I've really enjoyed myself, including the music, the great music. Thank you.
We have to build a hospital in Nairobi. We discussed last time to develop a hospital in Nairobi with our banner. I'll let you know later on. Anshu, my quick question to you, actually, when the healthcare is being talked about, and I was reading in the newspaper today only, and day before yesterday, and on the WhatsApp, one of the groups showing the bill of Corona. Satinder, please listen to that. It's very important. One of the WhatsApp group would show the bill which was paid by the Corona patient in some other hospital, not Apollo. I think it was Bombay. And the bill was something like 2 lakhs plus something, but for the stay of about 11 days. But people were having different types of comments. Why Corona patients should pay, number one. Secondly, how much patient has been patient doctor, the hospital has charged, number two. So, and now there was some guideline coming that they will fix up the charges. On one hand, they are requesting the private hospitals to please reserve the bed. All the hospitals are in loss because most of the patients, routine patients, are not able to come because of the fear of COVID-19. And on the other hand, they are saying that please charge a limited amount. There was a question whether PPE kit should be charged to the patient or it should be given by the hospital. So there's so many questions coming up. And whenever the hospital, any hospital charges a little amount or whatever, 2 lakhs may be a normal for 12 days of ICU hospitalization. And the doctor, Satinder, just listen to me, doctor who was treating him, who was going inside the COVID ward, who was receiving the calls from the patient family, was getting only 8,000 in 12 days or something like that, or maybe less than that. I did not remember. So whenever the healthcare is being taken up, although at one point they say you are godlike, on the other hand, whenever the bills come, how to differentiate and how to really tell to the public and the government both that after all, there is no grant coming to the government, the private hospitals, neither Fortis, Max, Vedanta, Apollo. They don't get the grant and they want the patient to be treated subsidized or free. From where they will do it, they'll stop working. So what is the solution in your mind? I'm sure you'll agree to my point. And I showed that initial slide also, that private hospitals are under pressure. So what is your take off regarding this issue where the government is pressurizing to do the line? Public is thinking that hospitals are taking too much money, doctors are not getting enough money, already squeezed economy of the hospitals, the balance sheet are zero, the regular hospitals. How will you cope up if it goes on for next 12 months or 6 months? The things will be very gloomy. Please answer this question as per your perspective.
Sure. I think number one, I think the coronavirus patients, COVID-19 patients need to understand that there have been a lot of measures that have been announced to make sure that they do not get infected. by whatever reasons they get infected, they are a risk to public health. So, which is why I think it's justifiable that they should pay to be quarantined, or they should pay to get treated. And so, in terms of, I think, people criticizing the cost, I think, I think that's an issue of entitlement. I don't think anyone should be criticizing the cost at this moment. Like, you can always choose between different hospitals or the different categories of rooms that you take. But I'm not in favor of anybody criticizing the cost that it is taking to recover from a pandemic that the whole world is suffering from. And in terms of government, I think government is in a lot of pressure with, in terms of policy making, and also from the diplomacy point of view, they have to say things which should sound right to the masses. It may not be something which they personally believe, or would personally, like, in the sense that they would agree to criticism of costs that a particular hospital is putting into the patient, but they have to do certain things which are going to be accepted on a wider scale. But I am also, of course, in favor that there needs to be some measures taken by the finance minister, which does incentivize the private hospitals, because this is going to continue, and before it gets worse, we need to have measures in place.
Very much. I think your thoughts is okay. That means there should be some sort of a limited grant, Satinder, you'll agree, coming from the government to the private hospital if they want to curb or limit the costings, because the hospital will not pay from the pocket. Okay, thank you very much. It was really nice. Dr. Johar is there finally, because he's been coming with us. He wants to speak something before I can conclude this meeting. He's from Dehradun.
Unmute him. Please mute.
I'm trying to unmute, but
can you hear me?
Yeah, please. One last, just a comment. Yes.
Thank you, sir. I am listening to and I am a scientist here. So our Uttarakhand government, our chief minister has announced 50 lakh rupees for private hospitals. This I wanted to share with you.
Oh, I didn't know this. This is a very good.
Our Uttarakhand chief minister, he has announced that he will give 50 lakhs to the private hospitals who are treating COVID patients.
Okay, that's a very good news. I think the central government and the government of Uttar Pradesh or government of Delhi should take a lead. That means something should be given so that there should not be a crunch at the level of private hospitals, so that they start.
Those people who can pay, I think they should support the doctors and the hospitals. They are taking their own life at risk. The doctors are taking their own life at risk. So at least those persons who are able to pay, they should pay it. It is a time. However, it will be compensated. Another thing, sir, I wanted to know from you. One of the, because now earlier the central government was regulating this, and they have now given to states. Now some state quarantine for in Uttarakhand, a person moved to the High Court that people should be institutionally quarantined. Now 6,000 people are coming to Dehradun daily. So in 10 days, it will be 60,000. And there the houses are very big, like 3 bedroom, 4 bedroom. Even my son returned from Bombay at that time. He was home quarantine for 14 days and I followed it. But now whosoever is coming to Dehradun is being institutionally quarantined. And my colleague's daughter, she came from Bombay and she has a 6-year-old son. So she was quarantined in a hotel. So what do you say about this? Some different states following different rules. In Delhi, Kejriwal has said that no quarantine. Actually, it is our responsibility. I proudly displayed the pamphlet outside my house that this home is quarantined.
I think it's an individual decision, but quarantine is important. If you really want to contain, if Delhi is growing like anything, same as Bombay, so I know it's painful to be quarantined, but if the public has to really support the government, and there is no solution to, as Dr. Gregg was saying, that they are able to contain this pandemic just by social distancing if they are really following it. Because our communities, we have a large population, we cannot do total social distancing. That's why I said mask, rumal or angocha. But I think quarantine should continue, and this is a policy, and this is a good policy, but it's painful, but it has to be followed. Otherwise, we'll never be able to get rid of this coronavirus. I think Satinder will agree to this. Any comment from your side quickly, and then we'll finalize.
In our city, one of our colleagues is quarantine, hospitalized, and his family quarantine. 2 days.
Home quarantine is okay. I think you should not go to the hotel or somewhere else. Now home quarantine is good.
That's the point. But his family has been quarantined in a guest house. Why? I am surprised, and we are surprised.
The same thing happened in one of the hospitals in Noida. What happened that he operated on a patient, and later on he turned to be positive. He's also orthopedic surgeon, and then he himself, the whole staff was quarantined in a guest house. I think it's important because we know that it is difficult for anybody. Home quarantine becomes next day you're relaxed. 14 days is a big time, and people are not so disciplined unless you really were fully disciplined to remain in one room inside the home. That's okay, but the government does not believe you, then in a guest house is better. For example, there is a friend of my son who's doing in AIIMS Bhopal. The duty, for example, Apollo Hospital, the nurses who are working in COVID ward, they work for 7 days and 14 days they are quarantined, but they are quarantined inside their own houses and guest houses. But they are supposed to follow the rules. If you don't believe your public, then you have to do in the guest house. If you believe the public, then we'll. Okay, thank you very much. I think this is a lot of questions will remain unanswered. We can continue for hours together. We have to finish this webinar. Thanks to Dr. Gregg Stone. The recording will go. He had to leave for a meeting with the FDA. Then thanks to Dr. Robert Matange from Kenya who joined and gave. Thanks to Madam Anshu Anand for the healthcare advisory, and as well as to Pankaj Jeswani for the songs, and Dr. Hakim from Nigeria. There was some video problem. Otherwise, he was supposed to talk about Nigeria. Muhammad Kutubuddin, Dr. P.K. Shokan, Dr. Yashpal Sharma, always our friends. Then Dr. P.P. Mohanan, the Political Society of India President-elect. And there may be some people who might have left, and Dr. V.K. Shah from Bombay. Thank you. I think this is time when we should close this webinar. And namaste to everybody, and good songs by Satinder and also by other people, and Dr. Johar, fine, good comments from your side. Thank you.
Pankaj Jeswani.
Thank you, Pankaj. Thank you. Bye-bye.
Thank you, sir. Thank you, sir. Keep remembering. Thank you.